Hi and welcome. I'm Steve Martireno, and this is the Behavioral Corner. You're invited to hang with us as we discuss the ways we live today, the choices we make, the things we do, and how they affect our health and well-being. So you're on the corner, the Behavioral Corner. Please hang around a while. Hi, everybody. Welcome again to the Behavioral Corner. It's me, King of the Corner, Steve Martireno. We're here talking to interesting people. We hope you find them interesting. We do, and they cover everything, as a matter of fact, because everything affects our behavioral health. The corner is made possible by our underwriting partners, Retreat Behavioral Health. You'll hear more about them down the road. I want to address real quick at the top of the program the youngins out there. There may be some youngins watching the podcast or listening to the podcast. I'm going to tell you a story that you probably may have never heard about. There was a time when, if you were of a certain age, doctors made house calls. Now, I know what you think a call is, but this is different. This is a doctor that you called, your family physician, and said, Dad's not feeling well, or the kids are out of school, they're not feeling well. Can you come on by and take a look at them? And believe me, kids, the doctors used to do it. It was a venerable part of medicine, the house call. If you don't believe me, go check out Leave It to Beaver, and you'll see their family physician show up. It happens, I'm sure it still happens. My guest is saying it does. It does not happen the way it did in my youth, believe me. Although, having said that, doctors now do make house calls, but they don't do it. In fact, they do it virtually, the way we're doing this interview. They do it over the internet. It's telemedicine. It has exploded out of use, initiated or hyper initiated because of the pandemic and a public health emergency declaration that the CDC made that allowed doctors to do this. We have that story to tell you very quickly, and then what has grown up around telemedicine that presents perhaps problems. In fact, we know it can present problems. To join us and fill in some of those blank spaces for me is our great friend, Dr. Jonathan Beatty. Dr. Beatty has contributed to the program in the past, and I hope he continues to do that. He's a great source for information. This doesn't do his resume or his background justice, but succinctly, he is an addiction psychiatrist. And we welcome him back to the Behavioral Corner. Dr. Beatty, thanks for joining us. Did I get most of that right?
You did, Stephen, and thanks for having me back to the show. It's a pleasure to be here, and I'm looking forward to talking about this very interesting topic. And just to say, for the record, I actually made a house call probably about 2 weeks ago. So I do, on occasion, in real life, make non-virtual but actual house calls. But it is definitely, much less common than it was in the era that you're talking about and describing.
Yes. Yeah, it was just a normal course of affairs that doctors would come to your house, and they do now, but they do it virtually like everything else. And therein lies our story. This explosive, I knew people were using telemedicine, I'm sure, for a very long period of time prior to the pandemic, but it was the pandemic that put this thing into hyperdrive. Tell us a bit about that.
Absolutely. And you're correct in that the telemedicine existed, it long predated the pandemic. So virtual, what they call synchronous telemedicine, meaning that it's a live video and audio feed between a patient in a remote location, could be their home or anywhere, and then the clinician, or usually the physician, from their office, or I guess theoretically from wherever they might be. And so the idea of expanding care and access to care by doing this led to the development, I think it's the American Telehealth Association or something, ATA, I believe, whatever that stands for. So they created guidelines behind how this is, again, way before the pandemic of COVID-19. And there was a lot of hesitation for this to kind of get rolling because we're trained in hospital settings, we're trained in office settings, we're not trained in virtual settings, and many of us are not all that familiar with, depending on how old the physician is, the technology behind it. And so there are also some limitations in terms of tangible the patient's not directly in front of you and you may not be, so there's this hesitation. And the guidelines, as I recall, and don't quote me, but I think more or less were that initial visits were intended to be in person, and follow-up visits, the guidelines would suggest, were adequately monitored and processed through the telemedicine platforms. So then you get to let's say 2008, where there was a situation regarding an online pharmacy, I believe, and or doctor that was prescribing, and there was a patient, and I'm not 100% certain of I believe the patient is Ryan Haight. I can tell you that the act that was developed is the Ryan Haight, and that's HAIGHT Act of 2008. My understanding is he was a patient who was prescribed from a few different locations, multiple prescription medications that were controlled substances, and subsequently, I guess, succumbed to those medications. And as a result of that, they identified that through the DEA, that one of the requirements for prescribing controlled substances is that you need to have met the person face to face, the patient, prior to initiating any prescription for a controlled substance.
Was Ryan Haight, was he being treated for a psychiatric disorder?
I'm not certain of that, so I don't want to comment. Okay. I'm not positive. But regardless of the purpose of their treatment, the controlled substances, my understanding, were at least in part, if not entirely, behind.
There was a bright line what the physician could do in a virtual capacity, and it stopped at prescribing drugs.
Right. Well, specifically
opioids,
controlled medication. So you could, let's say, at any point in time, I've never met you before, and you say, "Hey, I think I have strep throat, or I have a really, whatever," and I might say, "Oh, I'm going to give you this antibiotic." And I can prescribe that from our evaluation. I can maybe even be able to see your throat. If you can shine a light there, I might be able to see it virtually and identify, that it's very red and irritated and there's mucus and so forth, pus, whatever, and be able to treat it that way and send the electronic prescription for an antibiotic. That I don't have to meet you face to face for, and still don't. But as a result of this outcome, if it were, "Hey, I'm really anxious and I need Xanax," I mean, paraphrasing, obviously, or I felt you needed Xanax, I would have to, up until the pandemic, as a result of this act, I'd have to see you face to face, and then subsequently at least once a year in person. So we could meet any number of times between those that year, but at least once a year would have to be in person. The rest could be virtual.
And the logic behind that is obvious. It's in the description of the drugs that you couldn't do that to. They are controlled. Right. And if you were to be able to do that without actually seeing the patient, then you're losing the control over what potentially could be a dangerous drug, and also, I suspect, can lead to abuse of that drug. Correct?
Very much so. So those are two important distinctions. And then there was another element of the guidelines which remained in effect until the pandemic that had to do with state lines. And so, generally speaking, a physician is licensed in the state where he or she practices medicine. I mean, they have to at least have that. Sometimes they do have additional licenses. For example, I'm in Pennsylvania. A lot of patients come from New Jersey. A lot of doctors in Pennsylvania think it makes sense to have a Jersey license as well. So I happen to have one, although I don't know that I ever actually use it, but I have it. That being said, the patient location defines the state licensure requirement. And by that, I mean, if a patient is in Pennsylvania, like you're in Pennsylvania, if you were my patient, I'm licensed to treat patients in Pennsylvania. I can do that remotely because you're in Pennsylvania. Likewise, if you were in New Jersey, I could because I happen to have that license. If you were in Alaska, I would not be able to practice medicine in Alaska because I'm not licensed there. So I would not be able to have a telehealth visit with you if you were in Alaska. Now, I could be, as the physician, I could be anywhere in the world theoretically, but the patient I'm treating has to be in the state in which I'm licensed. Yeah, that's another important distinction when we get into the pandemic.
Again, for obvious reasons. So what changes when the pandemic hits? What changes?
So we are then entering into what they refer to as a state of emergency, which there's the emergency use authorizations, the EUA, that allowed for a lot of the rapid tests that were developed for COVID-19. Some of the treatments for COVID-19, at least initially, even the vaccines initially, which are now fully FDA approved, but at the time they were emergency use authorized. So what that means is during that time period, there are lots of exceptions because they don't want to delay access to care. They don't want to limit access to care. And so in order to, the greatest common good would be to make sure every patient is able to get to their doctor. So the compliance of the software that you would use for the telemedicine was also lifted somewhat, the requirement that it had to be HIPAA compliant so that there's an encryption between you and me so that a third party wouldn't be able to intercept that because it's protected health information. That changed to a point where you could theoretically use like a Facebook Messenger or an iPhone FaceTime or one of these things just during the pandemic. And I suppose technically until May of this year, when they end the state of emergency, you might be able to do that. I never did that. I didn't think it was a good idea, but I was able to incorporate a telehealth platform that I had already been using ahead of the pandemic in a much more limited capacity to roll that out into a major part of my practice.
So people had to be confident that while they meet their doctor and are treated by him or her virtually over the internet, it was protected so that no third party could see what drugs you're taking.
Or whatever the conversation,
whatever condition,
they could theoretically hear you talking about, whatever disease state you're, all that is confidential. And so it's important to maintain that confidentiality. It's always important, but because of the emergency state, they were making it a little less stringent. You were obviously supposed to do the best you could under the circumstances.
Yeah. We don't need to go over the history of the pandemic. We know that, as you've already pointed out, a lot of things were, a lot of guardrails went down, was full speed ahead on getting certain things done. We'll worry about whether or not there's any efficacy to this stuff later on. We got to get out in front of this national, international critical emergency. And so telemarketing got itself on steroids, telemedicine found itself on steroids, doing all sorts of things it was really never intended to do. The problem now arises with regard to, I guess, any number of doctor-patient interactions, but specifically what piqued our interest is I see online every day ads for the use of certain, for a lack of a better term, we'll define later, psychedelic drugs or mood drugs to treat things like depression and bipolar anxiety and stuff like that are now not only diagnosed virtually, but you can be prescribed specific drugs to treat these and never have to leave your house. That's a problem, right?
Well, it's certainly a potential problem. It remains to be seen on some level, but I think it's important to identify that psychiatry and mental health in general is well positioned, I think, for telehealth visits because of the fact that there's not as much of a physical examination necessary, although I would argue there are certain things that are necessary, such as checking vital signs, identifying drug screens and other things to identify what else might be going on that you can't pick up through a video call. I mean, even the smell of alcohol, frankly. So there are limitations, but nonetheless, compared to, say, cardiology and needing to listen to a heartbeat, that would be somewhat difficult, although there are ways that they can now do that. But point being, sorry, go ahead. You had a question.
No. I'm looking into the future, and I can see a situation where, first of all, this won't be foreign. This will be a common experience. The technology will catch up to it, and you probably will be, in fact, probably can now do vital, the 5 vitals.
There are types of hardware now available that can go to the patient's house. You could mail them theoretically, and so there are ways of monitoring remotely things like vital signs. But so
the people understand. So where we are, we're on the cusp of, we're at sort of an inflection point. What we're talking about as a potential problem is in its infancy right now, but going forward as virtual healthcare, telemedicine becomes more ingrained. There are going to be generations who grow up with know of no other relationship to their physician than this, what we're doing.
The so-called new normal that we heard about all along, and
exactly
ongoing.
Well, we have the accident of birth to all be at the moment when it's being figured out.
Right. So let me give you a quick sort of example that would be appropriate use of telemedicine in psychiatry. So let's say, for example, somebody is depressed. they contact our office and they'd like to get evaluated for what they think is depression. We might be able to do that virtually by a telemedicine appointment, visually seeing the patient and then collecting the history as we do, identifying certain symptoms and trying to funnel that into some form of a diagnosis to oversimplify it. And that treatment plan might then be an antidepressant medication to be prescribed. I don't see any, I mean, there are some potential limitations, but for the most part, that's a pretty reasonable approach. Especially when you consider how debilitating depression can be, and somebody might not be able to leave their home. And the thought of having to get a ride or get themselves to you, or even get out of bed and get a shower and get dressed might be daunting. So other than the potential risk of suicide, which of course is a very grave concern, the idea that we could increase their access to care by doing it remotely is potentially a win. So let's say that in that scenario, the person is depressed, not suicidal. We give them an antidepressant medication prescription electronically, and they start the medicine and they start feeling better. And maybe when they're feeling a little better, they're able to come in for an actual in-person visit. That's a slam dunk, right? I mean, that's like what we would hope for. Now let's add to that a little bit of anxiety. Now let's say they are not responding to the antidepressant medication as much for the anxiety as they are for the depression, and maybe you're considering something called a benzodiazepine. Well, now you're dealing with a controlled substance. So now in the pre-pandemic era, we would have to have the face-to-face evaluation prior to that. There are a lot of advantages to that when you see somebody in real life. Again, like I alluded to, you can evaluate and assess, you can collect, urine drug screen, you can do other things to try and identify if there's a greater chance of this person abusing the substance down the road, or if they're already abusing something else, quite frankly. I mean, a patient could tell you, no, I've never taken a benzodiazepine in my life. And then you do a urine drug screen and they have, 3 different benzodiazepine positive results in their drug screen. So there is value, obviously, in the in-office, and I would never diminish that. But there are scenarios like the first one where it can be very helpful to have the telehealth. So
and as you pointed out in your initial remarks, there are people who, because of their circumstances, that would just be cut off from care because they're unable to come in to see the doctor. So this was a boon to a lot of people.
Exactly.
But it was born out of an emergency. That emergency directive is about to lapse, is it not?
Right. So the idea that it did exist prior to that, but then it accelerated to the point where 5 or 10% of physicians had the capability of telehealth, and I don't know that exact number. That's just a guess. And then among those percentage, maybe I'll use myself. So I had the capability. I would say less than 5% of my patients pre-pandemic I would visit through telehealth. And now it went up. I guess there was a brief period of time when it was nearly 100% because it was almost the only way to conduct healthcare. I mean, our doors were always open and we had a lot of precautions in place, but a lot of facilities don't have the capabilities to do so. And as you recall, the protective equipment, the personal protective equipment wasn't available. So yeah, the pandemic accelerated. I mean, it threw gasoline on this fire, so to speak, and made it really available. Which again is a good thing in some and probably even most ways. But then I think what we're getting at is what else could you use to treat depression? And there are some other medicines that are around to treat depression that were not considered to be safe to be treated at home prior to the pandemic, and that has since shifted. And so what I'm talking about more specifically is ketamine and a more novel compound, which is really just a portion of ketamine called S-ketamine. So S-ketamine, branded as Spravato by Johnson & Johnson, was approved as an in-office treatment for depression. What that means is the patient would come into the office, receive the dose of medicine that was kept under lock and key in the doctor's office. There's all kinds of DEA requirements to avoid or to protect against diversion. Has to be a certain number of keys locking it. It can only be there for 2 weeks ahead of the appointment. It has to be used within that period and so forth. We have to confirm after the dose is given to the DEA that it was given and to whom it was given and so forth. So there's what they call a REMS criteria, which is something the DEA has for a lot of different controlled meds. So that's risk evaluation mitigation strategy. And that's many times a much simpler method of identifying where is this medicine going, and who's getting it, and so on. I participate in those REMS as required for many different medications. The one for Spravato, which is this S-ketamine, is by far the most complex, even though it's a Schedule 3 drug, and there are many Schedule 2 drugs, which is a higher level of security or risk of abuse, as the DEA perceives it, that have fewer requirements, let's say. But nonetheless, ketamine and S-ketamine, they were being used in office to treat depression and other things, but we'll talk just for the case today about depression.
And in your practice, you have treated people with ketamine, as you just described.
I have, with both molecules, the racemic ketamine, which includes S-ketamine, and then the isolate S-ketamine, which is branded as Spravato. And so I've been using those ahead of the pandemic. They were approved very soon, or very, very shortly before the pandemic, if I remember the timing exactly. So I started using both treatment options. And prior to that, I had used ketamine in hospital settings for a variety of different circumstances. So pretty familiar with the medication, and I was pleased to identify these options in the office. One of the reasons that it's in the office is that you have to monitor blood pressure and other vital signs. You need to be sure the patient
during the treatment.
Right. Yeah. So they have to be in the office for at least 2 hours from the point when they start the medication. And that's so that the medicine can fully wear off, so to speak, almost like a post-anesthesia care unit. So these drugs are really anesthetic as they're classified. And so we're using sub-anesthetic doses, meaning they're not going fully to sleep. But the policy and protocol around monitoring is the same, meaning they can't drive afterwards. They have to be given a ride home, and they need to be monitored until they're sort of cleared from the medication.
The backstory of ketamine is fascinating, because we're talking about a use that grew out of its initial purposes, which was as an anesthetic.
Right.
But we've covered that, and we'll cover it in the future again. So we're talking to Dr. Jonathan Beatty. He is an addiction psychiatrist, and he and I saw several articles in a rush of mainstream news in the past week or so, and immediately began contacting each other, because we both saw a problem here, at least in terms of information for the public. This is the classic buyer beware, or know what you're getting into, what the situation is, before you fall into the easy pattern of listening to claims that you're bombarded with about these drugs that have some very wonderful results treating depression and even bipolar and anxiety, but you got to be careful. You've painted a picture in the history of telemedicine that sort of is a brave new world. It sounds terrific. Where's the problem start?
Well, in general, I think some of the limitations of telemedicine as it pertains to, say, abuse and diversion of medications and the inability to fully assess a patient and their response to medications. But I think in specifics, when we're talking about this particular medication, the ketamine or S-ketamine, the idea that so first of all, the DEA requirements for the S-ketamine, this REMS thing I talked about, they're worried about diversion. So if you're mailing this medication to someone's home, as some of the programs are doing, it's possible that medication could get diverted, obviously. Now, it's possible that any prescription for a controlled medication could get diverted. And so there's not necessarily a difference in risk about this drug versus another drug in terms of diversion. But because of this monitoring that's necessary, there are some other risks that are inherent to ketamine and S-ketamine. And so,
and one of them is its history as a recreational. It's a club drug. A Special K was a drug you took and went to a rave and had a wonderful time. So ketamine arrives into this story with a rep. And so I can see where the concern would be that it would be used that way again.
Sure. But again, I mean, lots of other medications are used in illicit ways that are prescribed and then not used appropriately. So I don't know if maybe there's just more of a sort of conception of this medicine in those ways that made that concern greater. But, I think.
Yeah.
Sorry, go ahead.
No, go ahead. No, I'm just saying, I think we understand the diversion concern and the potential to abuse the drug or, not use it properly. But assuming all of that is taken care of, Are there any dangers in, you've described a beautiful setting for how you treat patients with ketamine. They're in there, they're monitored, professional people are always around, they leave at an orderly time. That's a far cry from the ads I see on the internet, which is taking it home. What about the dangers to the patient? What are the potential drawbacks to telemedicine in that context?
So I think one of them, which is not insurmountable, or it is surmountable, is there should be another person, in my opinion, in the setting where the patient is taking the medication. So, for lack of a better term, a caregiver, somebody that's at least aware that they're there and that they're on this medication and they have some sense of what's going on. So I think if you have somebody there that is a trusted confidant of the patient, and you, the provider, have had a opportunity to have a conversation with the caregiver and say, okay, this is what if anything goes on, you call me directly. If we get disconnected, let's say we're doing a therapy session with the patient, but they're at home, then I can contact you, you can go check on them. So that can really help reduce a lot of the potential concerns. But these are impairing substances. So if somebody's at home and there's no real oversight of what they're doing, they could potentially become subject of abuse of some sort, meaning like if they weren't in a safe place where they took it, somebody could take advantage of them because they're anesthetized. I mean, they're awake, but their guard is down, certainly, from the medication. And so they need to be in a safe setting. And then, of course, if the blood pressure were to go above a certain threshold, that could be dangerous depending on the age of the patient. High blood pressure, acutely high blood pressure, can lead to strokes and heart attacks and other serious consequences. So there are some very significant considerations.
Isn't another one of the considerations, you say caretaker? It's obvious. If you're being administered a drug at home with no physician nearby, it's important just on the sort of garden variety stuff, blood pressure and stuff like that. Isn't it also unique to something like ketamine that you are also in an altered state of consciousness, so that a caregiver might not, what do I mean by this? Aunt Minnie, who comes by 3 days a week to make sure you're okay, who's 82 years old and doesn't know what an altered state of mind is about, might not be the right person to be with you while you're taking ketamine at home, right?
Yes, of course. The selection of the caregiver would be critical, in my opinion.
And different if you were just suffering from diabetes or something, right?
Very much so, yes.
Mm-hmm,
so,
mm-hmm.
I think it's important to have a concept ahead of that, what you're in for potentially as the caregiver, and make sure that person is vetted and adequately prepared for it.
Children of the 60s know who that person is. That's the guide. That's
right.
The person you have confidence in, the person that can keep you centered and get the most out of this treatment, the altered state you're in.
Right.
So that becomes a problem right away. Not how many people have that person available.
It would seem fewer than there should be. I think given the way that the medicine has become available in these ways, these send home or mail home drugs that are prescribed, and there's some sort of an evaluation, I guess, online ahead of that. Those types of requirements are not necessarily being met or even possibly considered or confirmed. And so it's hard to know what, I can give you a vague example without specifics, just to maybe drive the point home, that I have a patient who was considering ketamine on his own or her own, and ordered one of the, paid for and, signed up for one of these programs online, and had some kind of evaluation that he said was basically a few minutes, and that within, I don't know, a week or a few days or whatever, arrived in the mail a pack of 6 doses of this medication, or whatever the number was, and some visual aids, descriptions of what to look out for, and a number to take, to let them know if there's a problem. I mean, not a lot of oversight, it didn't seem. And frankly, the patient didn't feel comfortable doing it. And thankfully was able to tell me about it. So that was sort of my first learning about this type of program and this practice.
Let me ask you about where the drugs are coming from. I've read about, and it's a new phrase to me, compounding pharmacies. What are they? And are they reputable? Are they safe?
That's a great point that we should talk about for a minute. The compounding pharmacies are licensed pharmacies. They generally speaking should be perfectly fine and perfectly legitimate, with registered pharmacists or doctors of pharmacy or pharmacology who are licensed by the state as pharmacists who are able to compound these drugs. So if you look at over time, the beginning of time, doctors would compound their own medications, and that's how things started with medicine. Later, the School of Pharmacy was developed as a way to try and, broaden the ability to make different medications. And so theoretically speaking, that's part of pharmacy training. And then there's a more specific pathway, I believe, for compounding pharmacists, or at least in their subsequent training, to be comfortable doing that. So all that is totally above board, and as long as they're following the requirements that are state imposed, they're licensed by whatever state they make the medications in. They're using certain recipes that are specific for whatever they're doing. That should be fine. Now, what's happening though, and what you're talking about or getting at, is the idea of off-label use. Now, we use medicines off-label all the time, meaning it wasn't used in the manner that it was initially tested and approved through the DEA for. So. Even an antibiotic might be approved for a certain type of an infection, then they might find that it also helps in a different type of infection and use it for that. That might be an off-label use. Doesn't mean it's a bad thing. Now, with ketamine, the development of ketamine is intravenous use. So Ketalar, I believe, is the original brand name for ketamine. It's an intravenous, so in the hospital setting, as you alluded to, for anesthesia. Mm-hmm. It has since been used in other settings, but still in the intravenous preparation. And so that's being manufactured by the company that makes ketamine, as opposed to a third party, which again might be perfectly fine, but it's just different. So compounding pharmacies are allowed to make things that are not commercially available. So if ketamine and the concentration of ketamine in the liquid suspension is available a certain way commercially, they can make it in a different ratio that's not commercially available, and they're licensed to do that. And again, that might be perfectly safe. And those are sterile products that are still for intravenous use in that context. But they can also make non-sterile products. And so what we're talking about in this way is ketamine that's being compounded into another preparation, say intranasal, so that it's insufflated, basically inhaled, which is how the Spravato was done. So the FDA approved on-label major depressive disorder treatment with Spravato is a canister that you inhale through your nostril. It's not an intravenous route. Now, ketamine was tested. There was a nice NIH study done where they used 6 doses of intravenous ketamine to treat depression. It was very shown to be very effective, and so in most cases. And so the idea, can we compound IV ketamine or the ingredients of ketamine into this intranasal ketamine and use it? And the answer seems to be yes. Now, that's not what they're typically shipping out to these patient homes. What they're typically shipping there is what's called a troche, and that's basically like a lozenge that is sublingual or under your tongue. And so there's a different type of absorption under your tongue. The bioavailability is greater than if you were to swallow it by mouth. So your GI tract has a first pass effect, and many other reasons why the drug doesn't get into your bloodstream as easily as it would sublingually or intranasally, or the best route would be intravenously.
Yeah.
So they're sending these troches home, and that's how they're getting them. They're being compounded by these pharmacies. Now, that may or may not be appropriate. It's hard, by themselves, the pharmacies aren't, they're just responding to a prescription. They're not necessarily, mishandling that prescription by making what the doctor was ordering.
And without getting into too much detail about the compounding pharmacies, as you say, they are licensed. There are guidelines, there are protocols they have to follow. They have been, are they still as stringent on these compounding pharmacies when it comes to making the kinds of drugs you're talking about? I mean, are the guidelines there? Are people checking? Do they report to the government what they're doing?
I honestly don't know the answer to that. My guess is that they are. I mean, the ingredients that they're using to prepare the medications are highly regulated ingredients. And so for them to access those ingredients, I'm sure they have to log how they're using them.
It has to be a paper trail. Yeah.
Right.
Well, so how you can see what's happened here. A perfect storm has formed. And now, from what I've read, stuff you sent me and stuff I've found, entire practices that didn't exist, medical practices, are now popping up all over the country. They are driven by venture capital money because these guys see a potential huge payday.
Right.
And it's going to become easier and easier never to meet a physician, never be seen by a physician, to be diagnosed with some psychiatric disorder like depression or bipolar, and have a prescription written and filled out. This looks like, I'm sorry, it's a horrible term, but it looks like the formation of a gigantic, well, potentially a pill mill. I mean, we should be worried about that, right?
I think it's important to at least be worried about it. Yes, I'm not suggesting that's what's happening, although it's certainly a possibility. I think that in the pandemic, because of the restrictions that are lifted as a state of emergency, which are about to shift back, at least they're supposed to, that idea of that Ryan Haight Act that we talked about, so you would have to see the patient face to face. They're currently not required to do that, which makes a big difference when they're trying to grow a venture capital driven business as opposed to a medical practice.
Do you think the guidelines will be rolled back? They're supposed to be rolled back in May, right?
They are supposed to be rolled back in May. I think it's a little curious that, at least as far as I know to date, the FDA and or DEA has not given us a clear answer as to whether there's going to be any change in the way they are currently defined.
I don't know if you're a betting man. I'm not, but I would bet that there will at least be a notification that the status quo will remain while we take another look at this. I don't see where except from the public and people like yourself, professionals who are saying, slow down, why there would be any incentive to say, we're going to clamp down on this stuff. First of all, there are a lot of patients that are going to suffer.
Right. So that's where you're right. I think in the way they'll suggest it is, well, until we figure out, if we just cut this off now, suddenly 10,000, 20,000, whatever the number is of patients that are receiving this kind of care are going to, and it might be hundreds of thousands, frankly, are going to lose access to care, and that could be devastating. Which
and that many people who are true, by the way. Many people who are actually being helped through this process. And by the way, without getting too deep into the weeds on this thing, the growth has been nothing less than explosive. I mean, there are chat groups online where people who are being treated this way, 2 years ago, 3 years ago, there might be 4,000 or 5,000 people in the chat room. There are now tens of thousands of people in those chat rooms. So we know it's gigantic and getting bigger every day. I know we are pressed for time here, so we're going to have you back to have more of this. But just this final thing. If someone is looking for help and is inclined to look for help online, what are a couple of the 2 or 3 things they should be aware of before they decide this is the way to treat my problem?
Well, I think it's a difficult scenario when you're talking about somebody struggling with depression, because especially if they are dealing with what's called treatment-resistant depression or refractory depression, meaning it hasn't responded to the traditional medications or several trials of the right dose, the right timeline and all. So these are people that might be a little more feeling a little more hopeless, like, what am I going to do? And then they might genuinely be searching for a solution online, but because of the money backing some of these practices, let's say, for example, they might look for a psychiatrist who provides in-office ketamine. They probably wouldn't search for it that way, but maybe they would. Ahead of that result might be one of these sort of mail order companies, and they might click on it without even really realizing what it is, and it'll promise a very streamlined, easy approach to an evaluation and medication treatment for your depression, and that you can be feeling better by tomorrow or the next day. Now you take somebody who's been feeling depressed for maybe years and hasn't responded to what traditional medicines have offered. That seems like a really obvious, like, let me try that. And so I think what you should look for if you're seeking out care and you aren't able to come into an office setting would be, how sincere does the program or the practice seem? What sort of steps are they taking to safeguard you as a patient? Are they confirming, even for just a regular evaluation, are they confirming what type of safety is available to you? Do you have emergency contacts? Do you have the specific address of where the person is? Does somebody else know where they are? Because in the mental health field, one of the ways that our patients die is through suicide. And so it's important to be able to assess that carefully. And I think having a psychiatrist as part of the process is important. Not all practices involve psychiatry when they're doing these evaluations, or they may accept an evaluation from another provider. And so I think looking at the practice that if you're vetting it as a patient, trying to find out and understand how involved they are in the treatment plan.
Yeah.
Do they offer psychotherapy? There's more to this than medication. And I think we didn't really get into that, but it's important to understand that ketamine and esketamine are really good medications to help the process of treating depression, but they're not really meant in the general understanding of how these things work to be the only solution for treating depression. They allow and facilitate recovery from depression, but there's important other aspects of recovery that involve psychotherapy, good self-care, sleep hygiene, nutrition, all kinds of things that it's important for a practice to assess when they're treating a patient like this.
Well, it's all great advice, Dr. Beatty. I would just add this to what you've just said. The tendency to look at healthcare and treating what's troubling us should not be confused with the ease of buying a sweater through Amazon. We live in an age now where if you want something, you can have it tomorrow.
Right.
And these ads that you will see online, they may be reputable people, but they are appealing to this same instinct. Oh, yes. I just push a button and it'll be okay. Everything will be okay. This is not that.
I agree with you. That's a very good way to kind of summarize the issue at hand. It's that the culture is adapting towards that desire, and it's available in many other ways. And I think that healthcare still requires a little more time and nuance.
We thank you for your time, and we're going to have you back, of course, a lot. We've really just brushed the surface of this growing trend. Jonathan Beatty, thank you so much. Appreciate your time. I'll let you get back to your important work, and we'll talk to you soon, okay?
Sounds good, Steve. Thanks again for having me.
You guys, thank you as well. Don't forget, subscription. Look for the button. I'm going to make it bigger so you can find it, but it's there at the top of the page. Subscribe to the Behavioral Corner. We appreciate it. See you next time. Bye-bye.
Retreat Behavioral Health has proudly been serving the community for over 10 years. Here at Retreat, we believe in the power of connection and quality care. We offer comprehensive, holistic, and compassionate treatment from industry-leading experts. Call 855-802-6600 or visit us at www.retreatbehavioralhealth.com to begin your journey today.
That's it for now. And make us a habit, hanging out at the Behavioral Corner. And when we're not hanging, follow us on Facebook, Instagram, and Twitter on the Behavioral Corner.